ECG findings, considering that we have started from the baseline, standardization, and coming to axis deviation, whether LVH is there, whether P waves are seen, what is the rate. I'll just run a brief. See here the standardization. Initially he had mentioned if there were to be dampening, you would have got a slurring here. Now you calculate the rate for 6 seconds and multiply by 10. So here your axis is right axis deviation. It's a left axis deviation. And if you see for the LVH criteria, here the Sokolov criteria, here it is 20, it is 15, more than 35. So we have a left axis deviation, and you have a LVH, and you have a atrial fibrillation with a fast ventricular response in this ECG. Now, why has he breathlessness? Going to the physiology, if you see atrial systole or atrial contraction by itself contributes to a cardiac output, and it is more significant in patients with diastolic dysfunction like LVH and all. And if atrial fibrillation sets in, that atrial boost is lost. This is what I interpret from the ECG, what we are putting here. So this was a atrial fibrillation with a rapid ventricular response. Here the findings were irregular ventricular rhythm in that particular ECG. But the other correlations, what we got, discussed that. Now this is an 82-year-old lady with dizzy spells. Again the P waves, obviously I am talking about atrial fibrillation, almost all of the cases will be that. So the P waves are absent. The ventricular rate here is regular, it is not irregular. It is about 50, 300 by 6 or 7 or 45 to 50, in that range. And that one was a atrial fibrillation with a complete heart block. Now fibrillary waves of atrial fibrillation were seen, and there were no P waves, and the ventricular rhythms were regular. So complete heart block, there is nothing else but you have to go for a permanent pacemaker, irrespective of what the age is. Now in this scenario, the type of pacemaker you would put would be a VVI mode only, because there is no scope for a DDDR, the atrial rate being so high. This is a ECG of a 60-year-old woman with hypertension. The P waves are absent. The rate is almost 300 per minute on an average. What are the findings else you can see in this? Axis is left axis deviation. The QRS is slightly wider, and there is a QS pattern, and here is a broad notched R wave. So this is a ECG of a patient with the AF with left bundle branch block. It can be confused with ventricular tachycardia, but on a closer look, what differentiates it from a ventricular tachycardia is ventricular tachycardia should be regular. So on a closer note, if you take a caliper or and measure, you see here and all, there is a quite variation in the RR interval, which is quite manifest here, which would point towards the direction of a atrial fibrillation with the white QRS. In this particular situation, it is a left bundle branch block. Now this is a The history being a 47-year-old man with a long history of palpitations and lately blackouts. So if you see the rate is almost 300. It's very high rate. Normally the atrial fibrillation, the ventricular rate is in between the range of 100 to 160. In certain scenarios, you may get such a high rate. What could that be? Yeah. So in a WPW, generally they say FBI, like fast, the rates are very high, 300 at that higher rate. So it has to be an accessory pathway, or the AV node conduction should be very fast, unlikely. So here it is fast and it is a broad QRS and it's irregular. Now it's already made a diagnosis, so it's easy to tell, but when the patient comes first, it will be difficult. So if you have a baseline ECG which shows a delta wave in the previous ECGs, and now he has come with the palpitation, it makes your diagnosis easy. Now in the WPW, what is the significance? Now if the accessory pathway has a very short refractive period and is able to conduct the rate like this, the patient can develop ventricular fibrillation and have a sudden cardiac death. So how do you risk stratify? That is, in a WPW, if a patient comes with the ECG, you see a delta wave is there. Now if it is an intermittent one or on exercise, if the delta wave disappears when the heart rate increases, it suggests the refractive period is long and he is at low risk of developing sudden cardiac death or ventricular fibrillation, because the atrial impulses are not conducted down at that higher rate. This is a 75-year-old lady with loud fast heart sound and MDM, but in clinical scenario this would be a 32-year-old lady or a 24 in what we get to see by and large, mid-diastolic murmur when you say. So here the rate is controlled. Now what are the ECG findings you get to see in this? The axis is right axis deviation. It's a predominant negative in lead 1 and AVF is positive, right axis deviation. There is a persistent S in V6, suggestive of RV dominance, and there are absent P waves and irregular R waves. The clinical scenario, this favors towards in the presence of a mid-diastolic murmur in the mitral area, goes in the favor of mitral stenosis with the presence of RV enlargement. Now this is the various spectrum of ECGs of atrial fibrillation I just shown for to be familiar with. Now this is, here you can see the P waves. The P wave rate is about 300 and there is almost a 4:1 conduction, that is a atrial flutter. Now you look the last slide, it's a atrial fibrillation again, and here the P waves are absent. Now the second slide B, here the rate is as such, if you calculate, more than atrial flutter which should have been, and here the P waves are prominent. It's in between, called as flutter fibrillation. Whereas the third slide, it is an atrial fibrillation, and the fourth one is also an atrial fibrillation. The difference is that the P waves are slightly, or the fibrillatory waves are slightly prominent, and this is a coarse atrial fibrillation, and the last one is a fine atrial fibrillation. Now this is usually the dictum as what we discuss generally is atrial fibrillation has got a irregular rhythm. So in certain situations, as I already mentioned, where AF will have a regular rhythm, one when it reverts back to a sinus rhythm, the other situations when it have a complete heart block. Now in this case, this ECG, the first ECG, this all are atrial fibrillation, all have a regular rhythm, but the rhythm in this is, the rate in this is quite higher. It's about 1, 2, 3, 4, between 4 and 5, that is between 60 and 75. So in a complete heart block, as all doctor previously they have discussed higher, the escape rate of AV node is around 40 to 60 and the escape rate of the ventricles is about 20 to 45. So here the rate is about 60, so it's a junctional tachycardia. It's also discussed previously, junctional tachycardia's rates are between 60 to 100. So it is basically atrial fibrillation, and here the rhythm is regularized because of the presence of a junctional tachycardia. The next two slides, both are atrial fibrillation with complete heart block. Now the width of QRS tells us where is the escape rhythm. A narrow QRS tells the escape rhythm is higher in the AV node, whereas a broad QRS tells the escape rhythm is lower down. I won't be going much discussing about this, the pathophysiology. It could be either a focal impulse, focal activation, or a multiple wavelets, reverberating circuits. Now, from exam point of view, generally they ask, even though we are expected to know the PGs or the students, slight confusion comes in the last minute. Now, atrial fibrillation, the rate being 350 to 600. When do you call it recurrent? When do you call it paroxysmal? When do you call it persistent? When do you call it permanent? And when do you call it lone atrial fibrillation? Recurrent is 2 or more episodes. It's not one, it is either 2 or more episodes, then you call it as recurrent, and when it resolves spontaneously, you call it as paroxysmal. When it is lasting for more than 7 days, then you call it as persistent. And without cardioversion, if it lasts for more than 1 year, it is called permanent atrial fibrillation. Now, lone atrial fibrillation, when do you call lone atrial fibrillation? 3 things you need to see. One is idiopathic atrial fibrillation in the absence of structural heart disease or risk factors. Risk factors means no hypertension, age is less than 60, and other risk factors should not be there either, and structurally normal heart. Just a word about rate control versus rhythm control in the management of atrial fibrillation. There are a lot of trials, all those things. What we need to understand is rate control is preferred in older patients with persistent atrial fibrillation with hypertension or IHD. In the background of this, rate control is the preferred choice. In rhythm control, where it is preferred in younger patients, especially with paroxysmal atrial fibrillation. Now, in clinical side, they'll ask, what is rate, what is the target you want, or when do you say atrial fibrillation with controlled rate? When the resting rate is between 60 to 80 after medications, and on exercise it should not exceed 100 per minute. Now, what is the significance of atrial fibrillation? The risk of embolic strokes are very high with atrial fibrillation. You have a CHATS-2 score, that is congestive heart failure, H is hypertension, A is age more than 75, D is diabetes mellitus, S is stroke. For stroke, it's considered a very high risk factor. You give a score of 2. Now, total score is about 0 to 6. In a patient with AF, the risk of stroke with 0 score is 1.9 and increases to 18%. That is the annual risk of stroke, embolic stroke. In mitral stenosis, the risk of stroke is 4 to 6% per year, and the mortality is high when atrial fibrillation is associated with the other illness. Now, next coming, This is a 68-year-old lady on digoxin complaining of lethargy. Now the ECG shows that sawtooth appearance, which is suggestive of atrial flutter. The rate is already slow. I mean, they already mentioned here that the digoxin is there, so the conduction is the AV conduction is reduced, and that's caused bradycardia. Now this is a 57-year-old lady with palpitation. In this ECG, you see the ventricular rate is about 150, and there is a P wave. P waves are seen. Here are the P waves. What you can see in the P waves they are inverted in lead 2, lead 3 and AVF. Lead 2, lead 3 and AVF, and the heart rate is 150 per minute. You can see in the lead AVR the P waves are upright, which if it were to be a sinus rhythm is not normal. So here we have confusion. So what do? We give adenosine. That was a case of atrial flutter with 2:1 conduction, where the second P wave gets merged in the QRS complex and you are not able to make out. You can bring it out by either pharmacological or non-pharmacological ways. Now pharmacological is you give adenosine. Adenosine delays the AV conduction, so the flutter waves do not reach the ventricle, and hence when it is not, the QRS is not coming, that time the flutter waves become prominent. The non-pharmacological way is you do a carotid sinus massage, but before you do a carotid sinus massage, you look for a carotid bruit, whether bruit is there or not. Because if a bruit is there, the risk of you giving a stroke will be there. Now this slide has been already shown by Dr. Prabhakar, wherein you reduce the atrial flutter rate, and which results in an increased conduction across the AV node. That is, from 2:1 it has become 1:1 conduction. So controlling the rate might be detrimental. This is just to show a slide. Atrial flutter, there are two types, typical and atypical. In the typical, you have a counterclockwise loop, and in the reverse typical, it is a clockwise loop. Now, if this axis you see going up, the lead 2, 3 AVF will be down here in the Einthoven's this thing. So you can imagine the P waves will be negative in 2, 3 AVF, which is as the case shown here. Now atrial flutter is a macro reentrant, counterclockwise, clockwise, I mentioned about it. Now ECG findings, in the typical flutter, the counterclockwise, that is the negative flutter waves in 2, 3 AVF, and in the reverse typical, positive flutters waves will be seen in 2, 3 AVF. Now in atrial flutter, usually the conduction is more common with even number, that is 2:1, 4:1 or 6:1.
I now request Dr. Peter George, Professor of Medicine, FMMC, to hand over a certificate of appreciation to Dr. Krishna Shetty. Thank you, sir.